Recurrent Respiratory Papillomatosis, or RRP, forces patients into a relentless cycle of surgical interventions. Surgeons cut away the benign laryngeal tumors, but the tissue mass immediately regrows, sometimes requiring dozens to hundreds of operations over a patient's lifetime. This chronic recurrence imposes a severe socioeconomic burden, with direct healthcare costs exceeding $60,000 per severe patient annually. The standard of care fails because it only removes the transcriptionally active suprabasal layers of the tumor, the top layers that are already expressing the disease. The true viral reservoir completely evades the scalpel. The episomal HPV DNA resides deep within the p63+ and KRT5+ basal stem cells. HPV genotype 6 and 11 use the viral E2 protein to anchor this episome directly to the host's mitotic spindles, ensuring the viral code persists through every cell division. Surgical debridement addresses a surface-level mechanical problem while leaving the underlying localized immunological failure and the fundamental viral blueprint completely untouched. RRP is a localized failure of immune synchronization within the respiratory epithelium, rather than a generalized systemic immunodeficiency. The virus actively shields itself from host recognition by establishing peripheral tolerance, a state where the immune system ignores specific antigens it should otherwise attack. It enforces this suppression through the localized elevation of interleukin-10 and transforming growth factor beta signaling. Simultaneously, the viral E5 protein actively downregulates major histocompatibility complex (MHC) class I molecules. MHC class I molecules are surface proteins that present internal antigens to the immune system. Without these molecules, the infected basal stem cells become effectively invisible to circulating CD8+ T cells, the specialized white blood cells that recognize and kill infected cells. This biological stalemate creates a high-entropy attractor state, a thermodynamic concept describing a system trapped in a stable, non-optimal equilibrium. Eradication requires a coordinated biological intervention to forcibly rewrite these local instructions and break the self-sustaining immunosuppressive environment. We can frame the medical challenge of RRP clearance through a phenomenological phase transition model. A phase transition model describes how a system moves between distinct states of biological organization. This energy landscape chart shows the RRP microenvironment as a deep potential well on the left, labeled viral tolerance. The system is trapped in this state, dominated by Th2 and regulatory T cells. Baseline immune fluctuations lack the kinetic energy necessary to overcome the central activation barrier that separates tolerance from clearance. Transitioning the system requires a thermodynamic perturbant, a sequenced systemic intervention that injects enough energy to drive the microenvironment over that activation barrier. A systemic surge of interferon gamma neutralizes E5-mediated immune evasion, forcing the infected basal cells to re-express MHC class I and reveal their viral cargo. Once pushed over the peak, the system settles into a new, low-entropy cytolytic attractor state, where active clearance becomes the stable baseline. Curing RRP relies on executing this forced thermodynamic phase transition, moving the tissue from an entrenched tolerance state into active cytolytic clearance. While targeted immunotherapies like E6 and E7-directed DNA or adenoviral platforms exist, physically delivering these cells into the laryngeal mucosa is the primary challenge. The RRP microenvironment possesses chaotic hemodynamics driven by HPV-induced VEGF-A angiogenesis. VEGF-A is a protein that stimulates the growth of disorganized, hyperpermeable blood vessels. These leaky blood vessels generate severe outward hydrostatic pressure, significantly elevating the interstitial fluid pressure. This pressure acts as a physical wall against immune infiltration. In monotherapy trials, circulating effector cells fail to penetrate the basal reservoir, leading to eventual T-cell exhaustion as they remain stuck in the circulation. Without systematically dismantling this hydrostatic barrier, even highly specific immunotherapies cannot access the tumor microenvironment. To solve the pressure barrier, we utilize a multimodal blueprint that relies on strict temporal staggering of the drugs. This temporal sequencing timeline begins at day 0 with the administration of a primary DNA plasmid or adenoviral vector to initiate systemic E6-E7 immune priming. Following this injection, systemic expansion of E6, E7 specific CD8 plus T cells peaks between 7 and 12 days. We delay the administration of systemic bevacizumab, an anti-VEGF-A antibody, until day 4 or day 5. Bevacizumab's 48-hour pharmacokinetic onset creates a window of vascular normalization, reducing interstitial fluid pressure and stabilizing vascular flow. This delay engineers the entropic gate, a window where vascular normalization perfectly aligns with the maximum systemic release of newly expanded T cells. This alignment allows T cells to anchor into the tissue, establishing a durable retention plateau for sustained immunosurveillance. Temporal sequencing is the actual mechanism of action, creating a transient physical gateway for maximum immune infiltration. Waiting for anatomical tumor clearance is a lagging indicator. We must track the underlying immunologic shift in real time. A triadic biomarker panel, a system using 3 distinct metrics, can quantify the thermodynamic repolarization from a Th2 state to a Th1 CD8+ state. This chart shows the first metric, a steep, statistically significant drop in systemic Th2-associated chemokines, CCL17, CCL18, and CCL22, seen here as the plunging red dashed line. This drop signifies the physical dismantling of the chemical gradient used by the virus to recruit suppressive regulatory T cells. Metric 2 is the stoichiometric restoration of the IFN gamma to IL-10 ratio. Stoichiometry refers to the fixed quantitative relationships between chemical substances in a biological system. The intersection of these two trajectories at day 10.5 marks the definitive breaking point of peripheral immune tolerance. This crossover correlates with the destruction of the basal viral reservoir through granzyme and perforin-mediated apoptosis. These intersecting serum metrics prove the localized immune environment is structurally and permanently repolarized. Breaking tolerance is only the first step. Preventing virologic relapse is a challenge of cellular bioenergetics, how immune cells manage their energy over time. Metric 3 measures spare respiratory capacity, or SRC. SRC is a measure of a cell's ability to generate extra ATP during periods of increased energy demand. Exhausted T cells in the baseline tumor rely on inefficient glycolysis, marked by fragmented, disconnected mitochondria. Successful clearance requires memory T cells to transition to oxidative phosphorylation, where fragmented mitochondria physically fuse together into a dense, connected tubular network. This fused network provides the sustained ATP generation necessary to patrol the laryngeal mucosa indefinitely. Mitochondrial fusion and elevated SRC provide sustained energy for lifelong immunosurveillance against the basal reservoir. This multimodal phase transition framework is currently advancing toward clinical application. The objective is to permanently transition RRP management off of the high-cost surgical treadmill. Systemic vascular normalization and targeted signal injection rewrite the biological instructions, allowing the virus to persist. The medical community must stop treating RRP as a mechanical obstruction and solve the thermodynamic equation. By approaching the tumor microenvironment as an engineered system, this sequenced blueprint offers a testable pathway toward total virological eradication.